Welcome to Parasitic Diseases. Today we're going to discuss Cryptosporidiosis. It's a disease caused by Cryptosporidium parvum, which is an apicomplexan organism. That is to say that it's related to the malarial parasites that we discussed in the last episode of Parasitic Diseases. So where can we find Cryptosporidiosis? It's found throughout the world. It's a global distribution, and it infects many different kinds of animals, including humans. It was discovered in 1907 by Tyser, who wasn't even working on parasites. He was working on rudimentary genetics of mice. And when he came to looking at the small intestine of some of his mice, he discovered these round little objects on the surface of their cells. And he later on became so curious that in the subsequent years, instead of concentrating on the genetics of the mice, he concentrated on those little round dots, and they were later on named Cryptosporidium parvum. Now, the life cycle of all the apicomplexa reflects a complex life cycle that involves both an asexual and a sexual life cycle. And unfortunately for you, the taker of this online course, Cryptosporidium parvum will fall into that category of complexity. But I think we can work our way through the life cycle, and I'll show you the differences as we proceed down the intestinal tract of an infected host. Let's start with the infectious stage of this organism. It's called the sporulated oocyst. And there are 4 organisms inside this thick-walled cyst, and all of those organisms are haploid. It's reminiscent of what we would find in the oocyst in the stomach wall of the mosquito for the sporozoites for the malarial parasite. So these are equivalent to that, except that in this case, there's no insect vector. We just eat this oocyst that is contaminating our environment from the natural environment around us, like food and water. When we swallow this sporulated oocyst, it passes through the stomach unaltered and then enters the small intestine. Digestive enzymes then force the organism to exit from their thick-walled oocyst, and they immediately encounter epithelial cells along the gut tract and attach. Now, we think they attach by way of a 900 kilodalton mucin-like molecule, and I'll get back to that as we discuss the pathology of the infection. So they attach to the epithelial cells, and then something remarkable happens. The organism induces changes in the host cell that it attaches to, which causes the microvilli to fuse and to elongate and to form what looks to be like an intracellular inclusion of this sporozoite that attached to that epithelial cell. Once that membrane is completed, and the organism now feels that it's protected from the outside environment, there are other environmental cues that stimulate this organism to undergo an asexual reproductive cycle. So the sporozoite that attaches rounds up, and it forms what would be equivalent to the trophozoite stage in other life cycles, and we'll discuss those as we proceed through the apicomplexa. The trophozoite then divides by binary fission, producing 4 what would be equivalent to the sporozoite, but in this case, because it's undergone a division cycle already, its name changes to a meront. So now you have to remember another term, unfortunately. So this meront stage has the same capacity to infect epithelial cells as the incoming sporozoite from the sporulated oocyst. So that's some of the complexity here. So we see it's an oral infection. It infects the small intestine. The organism then attaches, and it undergoes a reproductive cycle. And this cycle can repeat itself for many times in an unexposed host, that is to say, a naive host that's never seen this infection before. And in doing so, it alters the secretory capacity of each of these columnar cells. And if enough columnar cells become infected, the patient, in this case, it is a patient, because they begin to exhibit signs and symptoms of infection. And one of those hallmark signs for Cryptosporidium is a watery, diarrhea, which contains almost no formed elements whatsoever, like fecal material. It can be so intense and so abundant that patients can exhibit 5 to 10 liters of loose, watery, diarrheic stool per day as the result of their infection. Continuing the life cycle then, as the infections becomes more robust and perhaps more synchronous, some of the stages that would ordinarily go on to replicate, they differentiate. And as you see, this arrow is going in 2 directions. So the trophozoite, instead of developing type 1 merons, differentiates the signals for which we are not aware of, that is to say, the molecular signals that would come from the host, maybe, or even from the parasite's life cycle itself. So we're not sure how this organism decides to do this, but nonetheless, at some point in its life cycle, instead of going on to replicate again, it starts to differentiate. And in differentiating, it now produces type 2 merons. Now, type 2 merons are distinguishable from type 1 merons by the fact that type 1 merons will just go on to replicate into more merons. In the case of each of these type 2 merons, they either become microgammons, or from another trophozoite, they could become macrogammons. These are altogether equivalent to the microgametocytes and macrogametocytes in the malarial parasite life cycle that we already discussed. So we can liken one to a male equivalent, microgametocyte, or the microgammont in this case, inside of which are produced small sporozoite-like organisms which are capable of fertilizing the female equivalent to the macrogammont stage. When the microgammont then enters the environment, the cellular environment of the macrogammont, they fuse, and after fusion, the organism moves from a haploid stage to a diploid stage. And that's complicated enough, but now there are 2 more options that the organism has at its disposal in terms of a developmental cycle. One option is to develop from this zygote, I guess we could call it a zygote at this point, into a thick-walled oocyst. This thick-walled oocyst is the one that goes on to replicate and produce haploid sporozoites, which then exit the host and are infectious for another host. That's one mode in which this organism gains entrance into a variety of hosts, as you can see here. These are some of its reservoir hosts. The other option, of course, is to, instead of producing a thick-walled oocyst, it can produce a thin-walled oocyst. And instead of leaving the host, it now re-enters this other phase of its life cycle and continues this, in this case, an auto-infectious life cycle. So this is a very complicated organism indeed. Now, I'm sort of adding human characteristics here. Pardon my anthropomorphizing this life cycle. But I don't mean to do that. But nonetheless, it's hard not to do that when you're talking about choices. And these choices are molecular choices, obviously, that are governed by issues of the development of immunity, the programs that this organism has at its disposal for morphing or morphologically changing into forms which either resemble the type 2 merons or the type 1 merons. The end result, of course, is if this organism becomes autoinfectious due to, let's say, the fact that the host is not responding immunologically in a normal fashion. The diarrhea that it induces can now be protracted for not just weeks, not just months, but perhaps years. Now, there are very few people that would survive a diarrheal disease that lasted years without heroic clinical interventions. And indeed, that is the case that we found when we initially discovered that here's yet another organism that can take advantage of an HIV/AIDS patient because their immune system is so compromised that the infection that would ordinarily go on to produce a week's worth of diarrhea now goes on to produce 2 or 3 months worth of diarrhea, with lethal consequences in most cases. So that's the life cycle of Cryptosporidium as it exists in both the immunocompromised host and in an immune-competent host. And here's that original section that I showed of Tizers, that he located this organism along the gut tract, and each one of these little dots is at a different stage in the development of Cryptosporidium. And in this case, of course, it's taken from a biopsy from an HIV/AIDS patient who unfortunately went on to succumb to the infection. The pathogenesis under which, the molecular pathogenesis under which this organism operates is not well understood. But nonetheless, we have in vitro models for this now, so we can investigate some portions of its life cycle. The attachment zone that is shown here in this elegant electron micrograph indicates the fact that this organism has a connection to the cytoplasm of its host cell, but it's also connected to the lumen of the small intestine. And the connection is different. Here is the microvilli that have fused together, as shown here. And over here we have a very interesting attachment zone, unlike any other organism that, at least in human infections, we don't know of any other organism that operates in this fashion. It's thought that it acquires all of its nutrition from the host cell through this interconnection that it shares with the host. At the same time, it wards off any adverse substances that might be in its environment. And now I'm talking, of course, about chemotherapeutic agents. The attachment, as I mentioned earlier, is due to a mucin-like molecule, which the organism produces on its surface, which is can be thought of as the attachment process of uniting this bottom portion, the apical end of this apicomplexan, with its columnar cells. And the proof of that is because we have an in vitro system, we can actually express this protein because we've got the incomplete genome sequenced from Cryptosporidium. We know that it's this 900 kilodalton molecule can be produced molecularly, and then you can expose the columnar cells first to the substance without the organism, and then introduce the organism and see whether or not we've been able to block the attachment site with its own molecule. And in fact, that was the result that caused these investigators to conclude that the attachment may be due solely to this 900 kilodalton molecule that it secretes as a way of attaching itself to the host. And now Dr. Daniel Griffin is going to give a clinical vignette illustrating the pathogenesis of this infection.
A 48-year-old from Bamako, Mali, who comes into the hospital in Washington Heights, New York City, with profuse watery diarrhea. He was born in Mali, came to the United States at age 18. He's been working here as a long-haul truck driver, but frequently returns to Mali to visit. Recently, he returned to Mali for his father's funeral and spent 3 weeks there, returning to the United States 1 week prior to the onset of the symptoms that are currently bringing him to our attention. The patient reports vomiting, weakness, no fever, but he says the diarrhea got so bad that he had to leave his apartment because there was diarrhea everywhere. He estimates that there's about 3 liters of diarrhea per day, maybe even more than that. A little more information about this gentleman. He is the youngest of 4 sons. His father, as we mentioned, just died. His mother is alive and well, and he works as a truck driver. He lives alone and reports paying for sex with professional sex workers. A patient was tested, and he was positive for HIV-1 clade B. He is noted to have an elevated viral load, and his T cells are less than 100. Now let's talk a little bit about clinical disease. Infection is usually initiated through ingestion of contaminated water. It can also be directly from an infected person or animal. sometimes in tainted food, and rarely through aerosol, but there have been some reported incidents where that has occurred. In an immunocompetent individual, the disease can vary from symptomatic infection with mild to profuse watery diarrhea. Upper abdominal cramps, anorexia, nausea, weight loss, vomiting are common features that are seen in the acute stage of infection. Now, cryptosporidiosis in an immunocompetent host is usually self-limited, usually lasts for about 2 weeks, but may persist for longer periods of time in some individuals. In others, the diarrhea may be severe with several liters per day. Even persistent diarrhea can go on to impact nutrition and growth. Now, a second infecting dose of oocysts after someone's been initially infected may present with no symptoms at all, or maybe a very mild transient diarrhea. Now, as we now know, children are the most severely affected group. And in this context, the diarrhea lasts longer. There's usually some associated weight loss. And after the results of a very large study, we now recognize that cryptosporidiosis is one of the 4 leading causes of diarrhea in children less than 5 years of age. Now, cryptosporidiosis in patients suffering from AIDS and other forms of immune dysfunction is classically chronic, lasts for months, even years, during which patients can lose several liters of fluid each day. The significant risk of mortality, and the case fatality rate in some of these series has been as high as 50%. Now, how do we diagnose it when it comes to our attention and we suspect this? Stool microscopy, PCR, antigen testing, and I'll say multiplex NAT testing. So let's go through these. Stool microscopy is the least sensitive test. Sensitivities are suggested to be as low as 30% with single stool examinations. You repeat them, it can be increased, and acid-fast staining methods are often required to detect this in stool microscopy. But in general, I'm going to say stool microscopy is a very not sensitive test, a test that is very limited as far as its sensitivity. What about PCR? Sort of moving on, saying we need a more sensitive test. PCR testing is highly sensitive. This also tells a little bit about which genotype, so it's been important in outbreaks and epidemiological investigations. Another option, antigen tests. These use monoclonal antibodies and actually have high sensitivity. They're easy to perform. They can be used both on feces as well as tissue biopsy specimens. But what has been changing a lot of things has been syndrome testing. There now are ways of doing multiplex nucleic acid amplification testing. Now that we're doing this, that we're saying let's apply this test to someone with diarrhea, we're starting to see many more cases of infectious diarrhea as due to Cryptosporidium species. Here you can see a beautiful picture of acid-fast staining of oocysts. But what about treatment? Now, here I'm going to give you treatment, but let me just say, it is not clear that any specific treatment is overwhelmingly efficacious. Now, people recommend nitazoxanide, 500 milligrams 3 times a day for 3 to 14 days, very broad range there. But there's limited evidence that any specific therapy is really going to make a big difference. So the focus is often on trying to restore whatever immune dysfunction may be putting this person at risk. So we'll show you nitazoxanide here. This is the only therapy approved by the U.S. Food and Drug Administration for the treatment of cryptosporidiosis. So what about our patient? Now, our patient had a multiplex GI panel, which was positive for Cryptosporidium parvum. Patient was started on nitazoxanide, and I would say more importantly, on antiretroviral therapy for his HIV. And he was stabilized with IV fluids because, as mentioned, there was a significant amount of fluid loss. The patient did slowly improve and eventually was stable enough for hospital discharge. The diarrhea had been greatly reduced, but it did take quite a while for the patient to improve.
Because this infection infects so many different kinds of animals, including birds, and all mammals that we've encountered, at least the domestic animals that we raise on ranches and cattle ranches and sheep farming and herding and goats, et cetera, all of those animals that we have come to accept as part of our agricultural expression, they can all become infected with Cryptosporidium, and therefore they represent a threat to the local communities. And when those farms impact reservoir systems, as we'll see in a minute, they can become a threat for large numbers of people. Preventing and controlling Cryptosporidium infection starts at the sanitary level, of course, to safely handle the disposal of feces. And we have two approaches. One is the good old-fashioned outhouse approach with a 6-foot hole, and the other is this modern water treatment system that you see here. They're both effective at keeping the oocysts of Cryptosporidium away from people. But when you've got a city as large as New York, which relies on surface water solely for its drinking supply, and that surface water is surrounded by farms, then there is the possibility, of course, of Cryptosporidium, at least on a seasonal basis, of infecting people through simply drinking water. The reason why I'm saying this is that New York City is very proud of the fact that they lightly chlorinate their water, but it's not filtered. The unfiltered drinking water of New York City is drunk by virtually every citizen that lives within New York, and there are 8.5 million people, so that's an awful lot of people drinking water without any adverse consequences whatsoever. If this is to continue, this watershed needs to be isolated from the farms that are lying just on the other side of these mountain ranges that you see here. That requires a huge expense on the part of New York City and for other cities that have as their drinking water supplies surface water rather than pumping it up out of the ground. Now, recently we've learned that Cryptosporidium has a genetic propensity towards, that's the best way to put this because it's not clear yet that that's the case. But if you were to sequence Cryptosporidium species, which infect these wide varieties of animals, in addition to parvum, there are many other related species, and then compare them to a group of animals known as gregorins. They're an apicomplexan group that primarily infect invertebrates like insects and cold-blooded vertebrates. Then you would find that instead of aligning itself with, let's say, Toxoplasma gondii, which is another apicomplexan that we'll be discussing soon, or malaria, this is an organism that probably evolved from the gregorin group of organisms to, through mutations of various sorts, to finally become adapted to life inside of a mammal. We actually have devoted an entire episode of TWIP to the discussion of an outbreak in Milwaukee, which involved some unusual events, some weather events, and some repairs of filtration events, which created a perfect storm for that unfortunate city and resulted in one of the largest diarrheal disease outbreaks recorded in modern times, with 400,000 plus people becoming infected and lots of people with HIV/AIDS who did not know that they had HIV/AIDS. They suffered greatly from this infection, and of that group, 200 succumbed to that infection. So I highly recommend listening to this episode to get further details on the epidemiology of this universally accepted organism in terms of humans and other mammals, the one that's found around the world, and one that could be one of the major diarrheal disease producers that we can describe to you through parasitic diseases. So thanks very much for listening, and look forward to seeing you next time.